Welcome to today's Explainer. We are diving straight into the fascinating and honestly super fast-paced world of modern heart failure management. If you follow cardiovascular care at all, you know this field is advancing at breakneck speed. Today, we're unpacking the management strategies outlined in recent clinical frameworks, specifically the pivotal Chapter 265 data. We'll be covering everything from preserved ejection fraction and acute decompensated states all the way to life-saving electrical interventions. So let's just get right into it.
Here's our roadmap for today. We'll quickly hit heart failure phenotypes, managing preserved ejection fraction, the core pillars of HFrEF therapy, handling acute decompensated heart failure, and finally, preventing sudden cardiac death.
Section 1. Heart failure phenotypes explained. To really understand these pathways, we have to establish one absolute fundamental concept: ejection fraction, or EF. This is simply the percentage of blood leaving the left ventricle each time it squeezes. And it's not just a random functional metric, it is literally the foundation of everything we're discussing today. From this one single number, the entire diagnostic tree branches out and tells us exactly which therapeutic path a patient needs to take.
Based on that EF number, we see a massive mechanical fork in the road. On one hand, you have heart failure with preserved ejection fraction, HFpEF, where the EF is 50% or higher. Basically, the heart pumps just fine, but the muscle is stiff, so it fills poorly. It's essentially a plumbing issue. On the flip side is HREF, which is heart failure with reduced ejection fraction, where that EF drops to 40% or below. In this scenario, the heart is fundamentally just a weak, failing pump.
Section 2. Managing preserved ejection fraction.
For a long time, dealing with HFpEF was incredibly frustrating for clinicians. We didn't really have therapies that actually reduced mortality. It was almost entirely about symptom control. You had to aggressively manage all the underlying comorbidities, you'd use diuretics to clear out the congestion, meticulously manage blood pressure, and control atrial fibrillation. Basically, we were treating the company the disease kept, things like obesity, diabetes, and sleep apnea, rather than treating the disease itself.
But man, look at how things have changed. SGLT2 inhibitors represent a massive, incredibly exciting paradigm shift. Originally, these drugs were designed exclusively for diabetes, but recent trials proved that they dramatically reduce cardiovascular mortality and hospital visits for HFpEF patients. It was this serendipitous discovery. They offer powerful protection for the failing heart, completely regardless of whether a patient actually has diabetes or not. Total game changer.
We're also seeing some wild new frontiers with lifestyle and targeted comorbidity treatments. For example, recent data shows that using GLP-1 agonists like semaglutide drives significant weight loss and massively improves the functional capacity and quality of life for obese patients with HFpEF. After years of just hoping to relieve symptoms, we're finally moving toward powerful, disease-modifying therapies here.
Section 3. The Pillars of HFEF Therapy.
Now let's flip over to the other side of the algorithm, HFrEF. Unlike HFpEF, this side has had a rock-solid evidence base for a long time. We rely on 4 essential pillars of pharmacotherapy. Step 1, your RAS blockers or ARNIs. Step 2, beta blockers to shield the heart from adrenaline overdrive. Step 3, mineralocorticoid receptor antagonists or MRAs. And Step 4, there they are again, those breakthrough SGLT2 inhibitors. When you stack these 4 together, they actively block harmful neurohormonal pathways and literally help the ventricle recover.
While those 4 pillars are the standard foundation for almost everybody, we can dynamically tailor and stack other therapies based on a patient's unique demographics. Say you have an African American patient with advanced HFpEF. Adding a combination of hydralazine and nitrates has been shown to uniquely improve survival. Or if a patient is fully optimized but their resting heart rate is still stubbornly sitting over 70 beats per minute, we can bring in ivabradine for targeted heart rate reduction. This is what highly personalized medicine looks like.
Section 4. Acute decompensated heart failure.
Okay, so what happens when those chronic pillars we just talked about fail? A patient is rushed into the hospital with an acute crisis of severe congestion and hypoperfusion. This is acute decompensated heart failure, or ADHF. It is a severe, life-threatening crisis. In this moment, our focus completely shifts away from long-term remodeling and goes directly to rapid hemodynamic stabilization.
To rescue a patient in this state, we rely on a very specific acute toolkit. First, hit them with intravenous loop diuretics to aggressively pull off that excess fluid and relieve pulmonary congestion. Second, we use vasodilators, like nitroglycerin, to drastically drop the mechanical resistance the failing heart is fighting against. And finally, if they are crashing into severe low-output shock, we introduce inotropes, like dobutamine, to forcibly augment the cardiac output.
But, and this is a huge but, we have to be incredibly careful with that third tool. Inotropes increase intracellular calcium to make the heart squeeze harder. Whipping a failing, exhausted heart to pump harder comes with massive electrical risks, and long-term use actually spikes mortality. So they are strictly bridge or rescue therapies. You're just trying to buy time, maybe to keep them alive until a mechanical assist device or a heart transplant is an option.
Section 5. Preventing sudden cardiac death.
This brings us to a really critical transition, moving from the heart's mechanical pump failures to its electrical risks. Sudden cardiac death from ventricular arrhythmias is how about half of all heart failure patients die. For high-risk patients, especially those with an ejection fraction under 35%, we implant a specialized electrical safety net called an ICD. The generator sits in the upper chest, and the leads thread directly into the heart chambers. It sits there watching every single beat.
And when it spots trouble, it acts fast. On the left here, a lethal rhythm, ventricular tachycardia, is detected, and the device actually paces the heart faster than the arrhythmia to break the cycle. That's anti-tachycardia pacing, or ATP. But on the right, when ATP isn't enough for a rapid, chaotic rhythm, the device delivers a massive, high-voltage shock, instantly rebooting the heart's electrical board.
Now, while these devices are undisputed lifesavers, managing them requires deep clinical empathy. A shock from an ICD is painful, out of nowhere, just a massive jolt. It can cause severe PTSD for patients. Because of that physical and psychological toll, doctors absolutely have to interrogate the device after a shock to make sure it was necessary and not just triggered by a glitch. Smart programming, like prioritizing that gentle pacing before jumping straight to a shock, is absolutely critical to reduce unnecessary trauma. We have covered a ton of ground today, from the fluid dynamics of an acute crisis to the microcircuitry of implantable defibrillators. I want to leave you with this provocative thought. As heart failure management shifts away from just broad symptom relief and moves toward these highly targeted, phenotype-specific therapies, how will the future of personalized medicine continue to redefine cardiovascular survival? I encourage you to keep exploring how these clinical guidelines are transforming patient lives every single day. Thanks for joining me on this explainer, and keep learning.